Let's turn our attention to artificial intelligence. Artificial intelligence, and we're talking about revolutionizing oncology with AI. And of course, it's the word revolution that comes back. And already at the podium, ready to speak, saving time, which is great for a conference like this. We have from Japan, Dr. Ryuji Hamamoto, Division Chief of Medical AI Research and Development at the National Cancer Center Research Institute in Japan. Welcome.
Thank you for introduction. My name is Ryuji Hamamoto from Japan, and my profession is artificial intelligence. In particular, today I'd like to share our current project entitled the Clinical Application of Artificial Intelligence in the Field of Oncology, Current Status and Future Direction. And I'd like to express my greatest gratitude to all staffs in G7 Cancer Conference. It is my great honor to make a presentation at such an important conference. So, okay, this is my CEO disclosure. The first topic is the overview of our project. In 2016, we, National Cancer Center Japan, started the project entitled the Development of the Integrated Cancer Medical System using Artificial Intelligence. And we, National Cancer Center Japan, possess a huge number of the medical data, including the clinical information, omics information, the PDX model, and medical images, and pathological report, and radio report. And once we established the NCC Integrated Cancer Medical Information Database, and using this huge data, in particular, the AI technology, the machine learning, and deep learning, we are developing the new cancer diagnostic systems, new drug design system, and support system for personalized medicine. And we also promoting the movement from R&D to industrialization. And in 2018, we started the PRISM project, development of artificial intelligence, accelerating the drug discovery. And in 2023, also medical data twin has started. Both of them are supported by the Cabinet Office Government of Japan. So this is the overview of the project in National Cancer Center Japan. Importantly, many clinicians in the National Cancer Center Hospital, over 20 departments and divisions have already participated in this medical AI project. Additionally, we also have several academic collaborators, RIKEN and the University of Tokyo, and AIST and the Institute of Science of Tokyo. And if we apply our findings for the clinical settings, collaboration with the companies is quite important. So we have several companies cooperating with us, like the Preferred Networks, NEC, and Fujifilm, Fujitsu, and Hitachi. So we have a lot of projects, but today the time is limited, so I'd like to introduce some of our achievements. The first is the AI project to support endoscopic diagnosis. So as you know, since neoplastic colorectal polyps precancerous lesions, detecting and removing them during a colonoscopy can inhibit their progression to colorectal cancer. And the physicians detect the polyps by macroscopic observation, but the polyps are easy to overlook if they are small or their shape is not clearly defined. So to address this issue, we developed the real-time endoscopic diagnosis support system using artificial intelligence. This is a summarized figure of our system. The important point is real-time. And algorithms for the morphological detection of lesions using a deep learning artificial intelligence. And endoscopic diagnosis at the color tone and the shape, texture, and the boundaries. And we're using high-speed processing algorithm. And real-time feedback, this is a quite important point. And sorry. This is the deep learning algorithm, the feature extraction identification, and the convolution layer, pooling layer, and fully connected layer. And we conducted the supervised deep learning method, and approximately 12,000 regions and approximately 250 images using for training. Then in 2017, we developed a real-time colonoscopy diagnosis support system using artificial intelligence. This is one of the pioneering achievements. This is okay, but the problem is how to use this achievement for clinical setting. This is a very, very tough way, because at that time, in 2018, nobody succeeded to use this kind of thing. AI-driven endoscopy, nobody is accepted. So we try to apply our findings for, anyway, the clinical settings. Firstly, we negotiated with the PMDA. This is the Japanese FDA system, and started the consultation. And also, we started performance evaluation study to obtain regulatory approval for the medical device program. And sorry. This is real video images, 20mm projected regions. Artificial intelligence quickly identifies the region and around like this. And finally, fortunately, we got acceptance of control medical device class 2 in 2020, and also meets the requirement of the CE mark standard for medical device product in Europe. That is, this product is currently being marketed by NIFI in Japan, Europe, in France. Also, this device is available now. And also, we apply these systems to identify the variant esophagus tumors. So in these cases, when an image is input from the endoscopy equipment, it is displayed on the left side of the screen and analyzed. When a tumor is determined to be present as a result of the analysis, a still image is displayed in the upper right corner of the screen, and the area predicted by the AI is displayed as a heat map in the lower right corner of the screen. And this is the first product in the world to conform to the CE mark. Also, this is available in Europe, also in France. Then next, we try to use a device for pathology diagnosis prediction. So this is a colonoscopy result and the detection model and the determination of the region location. And the pathological diagnosis is conducted by artificial intelligence, like the low-grade adenoma and the dysplasia. The automatically diagnosed region is the important point. So additionally, to prevent missed differential diagnosis, we developed a characterization model that automatically predicts the pathological diagnosis using the revised Vienna classification. This is the external validation data, the computer-assisted interpreted test, the independent image from training and neoplastic and non-neoplastic region. And this AI shows the same level of the performance with the specialist. And the important point is the inference time of the AI is 0.01 second. Endoscopist took about 2 seconds or 1 image. This is a visualization of the internal features of the CNN using the t-SNE, and this internal validation image are well classified by the trained deep learning models. And fortunately, also got acceptance of the highly controlled medical devices in March this year, and already on the market. This is pathological analysis by artificial intelligence. So future direction, so we will improve the accuracy of the artificial intelligence by having it learn to recognize flat or depressed regions that are difficult for humans to recognize. And it also aims to address the qualitative diagnosis of colorectal regions and the prediction of lymph node metastasis of colorectal cancer. And by linking CT images, pathological images, molecular biological information, and other information, we aim to develop a multimodality real-time endoscopic image diagnosis support system that is more highly useful and will further promote development and research towards the realization of advanced and personalized medicine and remote diagnosis. And the second is the AI project to support radiation image diagnosis. So in collaboration with the Fujifilm company, we developed the Synapse Creative Space and AI-driven support perform implementation in society in 2022. This system includes the data transfer, anonymization, annotation, setting up learning models, and training application of AI. We provide all-in-one platform to support AI development from the project management to AI execution. So if you have an interest in this product, please contact the Fujifilm. So especially the physician is very, very busy. So in some cases, a little bit to conduct the medical artificial by themselves. But if they use these systems easily to conduct the medical artificial intelligence research. And using these systems, we develop the new systems, Synapse Creative Space, and this technology is expected to be useful in the future for early detection of glioma, improvement of the diagnostics accuracy, and optimize the treatment plans such as radiotherapy and surgery by enabling pre-treatment image evaluation of the glioma with higher accuracy. Example is that of the extraction of the suspected glioma areas. Okay, finally, the AI project to support skin image diagnosis. So in this case, the motivation of this project is anyway, the patient should go to the specialized hospital as soon as possible in the case like the melanoma, that skin cancer. According to the paper, the mean time from the onset of the melanoma to going to the specialized hospital is around 5 years. So this is not so good, not only the patient for, but also the medical economics, because it takes a huge number of the medical cost. That is to stimulate the ordinary people if they have some anxious about the melanoma. In some cases, for ordinary people, difficult to distinguish between the malignant tumor like the melanoma and the moles. So that's and our purpose is, for example, using the camera of the iPhone to check the condition of the skin and analyzed by the artificial intelligence, and the AI stimulate the ordinary people to go to the specialized hospital. Then we also conducted the supervised learning artificial intelligence model, and using the 120,000 dermatology photo data in National Cancer Center, Japan. And this is the accuracy of our intelligence systems. Our AI model shows the higher accuracy than dermatologist and generally practitioner. But please be careful that this is just the still images. But in the case of the diagnosis, the physician also conducted the several kinds of the research. So that's the reason. But AI possesses a high potential to conduct the diagnosis of the skin condition. So our future plan, this is just the overview of our emission systems. So if we consider the improved diagnosis, we think the inside the hospital is not so useful, because the physician can conduct the biopsy of the skin and check the condition by a pathologist. But anyway, the ordinary people who don't recognize the malignant condition, we need to urge them to go to the hospital. So in such a case, the best case is outside. We use these systems outside the hospital. So like this, checking the skin condition by a camera on iPhone, and if the condition is not so good, like some malignancy tendency is observed artificial intelligence that simulate the people to go to the hospital and check by the dermatologist. This is ideal, but still we are going, technically it is not so difficult, but we need to consider some regulation law of this field. Okay, and finally, I'd like to show my greatest gratitude to the all members of the participated in my project, and also the in Natural Cancer Center Japan, the many physicians that they are very smart and hard workers support my project. Very, I would like to show my greatest gratitude. Thank you for your attention.
Thank you very much. Thank you very much. You can join me here. Flashes into the future, isn't it? The skin cancer mapping tool speaks to me. Growing up in the New Zealand sun, my dermatologist has a ongoing mapping system, so thank you very much. Yes, let's now turn our attention to what's happening in the UK. Professor Claude Shulala at the Barts Cancer Institute, Queen Mary University of London. And multimodality, we also saw that come up, and that's a theme for you as well.
Yes,
thank you very much.
Thank you. First, I'd like to thank the organizers for their kind invitation to this great meeting. I will show you, hopefully, I will convince you how a dynamic ecosystem with multimodal data can support AI for advancing precision cancer care. Oops, what did I do? Brilliant. But I also woke up at 4 a.m. this morning. So which one is it?
So as long as it's the green button,
the green button.
And that will advance it.
Yeah, it's definitely the 4 a.m. waking up. It's so clear. Okay, so I think we all agree that the performance of AI models is directly linked to the data that is used for their training, the quantity, the quality, but also the diversity and annotation of the data they are trained on. And we believe, I believe, cancer biobanks have a fantastic opportunity to evolve and be a foundational data infrastructure for AI development. So if you think about data diversity, multimodality, biobanks have specimens, they have tissues, they have blood, they have body fluids, they have cells, organoids, and they can generate a lot of multi-omics data and information that is used for AI. They can also work on the standardization and the harmonization. So you know there are a lot of common data models that are used for clinical data, not so much for translating the genomic concepts or the molecular data that is generated on patients from patient samples to be aligned and integrated with the clinical data. So fantastic opportunity for cancer biobanks. There is also a wealth of imaging data reports. So a lot of the information is in free text format. Fantastic opportunity for training NLP and LLMs. And also they can provide the ethical framework. So they could work with PPIE, with patients, with different stakeholders, and provide the framework for AI. And most importantly, their infrastructure, it needs to evolve, but it could very easily adapt it for federated learning and for the compute that is required to run the AI. So all this requires a pivotal shift in how biobanks are operated and conceived. I nearly pressed the off button. Okay. So I have the privilege to work with two national biobanks. I lead on the health informatics and bioinformatics data strategy for the Pancreatic Cancer Research Fund Tissue Bank and the Breast Cancer Now Biobank. Both are national. We collect from different sites across the UK. And my role is to lead a team that is working on harmonizing the clinical samples and data, the information that is generated on those samples and data, the radiological images, the free text, image reports, the pathological data, the path reports, but also the molecular data that is generated on samples from the biobank. I have to say, we are very proud, actually, that the PCR FTB has been recently awarded a biobanking ISO certification, and will be announced formally in 2 months' time. But I think this is a huge credit to the infrastructure and the excellent work that the staff have been doing. So our ambition when we set up the infrastructure for the biobanks was to make sure that we have an infrastructure that provides trusted access to cohorts with multimodal data, catering for the research community to support various research projects. We focus on unlocking and linking the information, as I've highlighted. There is a lot of work on standardization and harmonization to make sure that the data is ready for AI models, but is also ready for research projects. Clinical data should be enriched with new attributes that is coming from the molecular research. We don't have at the moment, we heard a lot about genomics, but there are no genomics concept or a CDM that would allow the integration of genomic concepts to support, for example, the work of tumor molecular boards, etc. So we need to work on this. All this work will not only cater for AI, but it will enhance the value of samples for research, and in turn will maximize the benefit for patients. And also having a national biobank on this scale will promote data sharing and collaboration, so will reduce the duplication of efforts. So together, both biobanks bring 18 NHS trusts from all across the UK, thousands of donors, tens of thousands of tissues, fluid and cell samples, a lot of thousands of whole slide images. Digital pathology is exploding at the moment, so we are building this. And a lot of our patients have been sequenced. So we have a collaboration with Genomics England, which means that a lot of our breast cancer patients have somatic and germline whole genome sequencing data. We have catered for over 300 samples and data requests and over 250 national and international research studies and commercial projects. We link the primary and the secondary clinical data. We want to know what the patient's trajectory was before they presented to the secondary care system and the tertiary care system. And we will want to provide a bioinformatics platform that would allow researchers to test their hypothesis, but also to validate their results on similar data. And this is a requirement for publication, so we support that as well. And we want to constantly evolve, so we want to be scalable, keeping our capacity and enrichment of modalities ongoing. We've published our infrastructure. I won't talk a lot about this, but you have the data and the samples at the heart of our biobank. We do accommodate linkage to the hospital EHR system and the return of genomics data. And we have different dashboards and application, a research catalog, but also interactive EOI and application system, a tool to mine the data that was generated on samples from the biobank, but also a cohort browser that I will show you very briefly to see whether we have clinical samples that are suitable for your research project. So from the beginning, we've built custom dashboards. We don't only cater for the research community, we do cater for the biobanking staff. So how do they curate samples, register samples, etc., and everything is audited. So when someone comes with a liquid biopsy project, they would want to know the time for processing the samples from the moment it was taken from the patient to the freezer. So we track and audit all this, and we can provide it to our researchers and applicants as well. I'll show you very briefly our analytics hub and our biobank sample browser. We have a research catalog that tracks the methodology, the papers, that tracks also the geographical locations of the projects that we've supported, and we think this is very important as a measure of success and contribution to the pancreatic and breast cancer research community. So our cohort browser, as you could see, you could query, you use combined criteria, linking the clinical information, demographics, diagnosis, and treatment, to the genomic information. So those are the variants that were found in the genome of those patients. You could see very quickly the availability of samples that we have, and the data that was generated was this patient whole genome sequenced, RNA-seq, etc. But also, do we have digital pathology? Do we have radiology? And if our projects have been published and the data has been returned, we will link you to the repository where you can find those data as well. The Analytics Hub is very important. So you could see here our Genomics England data return, and you can mine very quickly, without the need to be a bioinformatician, the clinical data, the genomics data that was returned, and you could look for your favorite genes or pathway, but very quickly you are building on information from the biobank, and possibly, if you are interested, you could go back and apply for matched samples and do another layer of investigation or omics modality. As I said, we're building the digital slide archive, so this is very important. Our whole slide imaging archive is increasingly getting bigger, but we have a metadata catalog alongside that as well. So you could very quickly look at the clinical information on the patient and see whether they have a whole slide image, and if they don't and you're interested and we have the samples, we will scan this for you. Now, examples, how can this be used? So it's not surprisingly, I work on pancreatic cancer and breast cancer, and being part of the biobanks is a fantastic opportunity, but I was infected by the passion for pancreatic cancer since I joined the Barts Cancer Institute in 2006. So I'll give you a little bit of examples using the breast cancer data because we have more rich multimodal information, and I will focus on liquid biopsy as an example for breast cancer research. So my first example is how do we look at clinical and molecular patient journey using different sources of information. And in this case, I'm going to focus on a breast cancer patient that has more than 5 years follow-up. We have information from the hospital, from the sequencing, and we've aligned all the rich clinical information with the DNA to build different layers of information on this patient. So, and very briefly, the data that we have from the hospital is structured or free text, and they use the coding system, the ICD-10 or PCS or SNOMED. We have manually curated data, so those are entered by our data curation team, querying the NHS system, but with the hat of a breast cancer researcher. So it's more rich in semantics toward breast cancer. And recently we've mapped this data to the OMOP, CDM, which provides another layer of standardization. And as I said, we have molecular data that has been generated on this patient. So this is the patient journey. So this is a female breast cancer patient that presented, that was diagnosed at the age of 70. We have information about the gender, ethnicity, diabetes, etc., comorbidities. We also collect information about the type of cancer, the diagnosis of primary breast cancer. You have the staging. They went into surgery, had adjuvant chemo, adjuvant radiotherapy, went into remission, sadly recurred, and passed from metastatic breast cancer. This data was manually curated and entered. Now, if we have a look at the data that comes from the hospital, so this is batch extract from the hospital, you could see that the data looks more structured, and also you would collect information not necessarily linked to their journey in the breast cancer clinic. You would see that they've visited other clinics. So, for example, they had an endoscopy, examination of their colon, and also you can enrich it as much as you want because our extract is querying all the nodes at the hospital to complete the trajectory of this patient. And we noticed that towards the end of life, there is a lot of coding that goes into the medical records, into the AHR system. Now, free text data is very important, not just for AI, but it's very important because it has valuable information that is not coded often in the patient EHR, structured EHR. So you could see here that we've highlighted using NLP terms that present a risk of recurrence because we work on breast cancer recurrence and we've used imaging reports as a way to highlight terms that might help us tag a recurrence or risk of recurrence for patients. And biomarkers for drug response. So as bioinformaticians, we query the whole genome sequencing, we call biomarkers for drug response and whether they confer a responsive or resistant phenotype to certain drugs. And as I said, this is at the moment not coded in the CDM that are used in the hospital, and I think this is the next challenge, and it will be a revolution if we manage to create genomic concepts and attach it to CDMs. Now, my next example is a recent study we've conducted on ancestry-associated differences and opportunities. We all can agree that racial disparities have a big impact on breast cancer statistics, with mortality being higher in ethnic minority groups. Social determinants of health can explain it, partially, but not fully. So it's very important that we focus on understanding how breast cancer develops and evolves in ethnic minority groups. In this study, we focused on linking multimodal data from different cohorts. Our biobank is very well structured, so we've linked it with other cohorts, such as Genomics England here, which is the 100,000 Genomes Project, sequencing patients from the NHS, Genes in Health, which is only focusing on South Asian, British South Asian, and the US initiative, the TCGA. And we compared patients from an African or South Asian ancestry to their European counterpart. I won't go too much into details. Our paper was published recently, but we found that non-European breast cancer patients are diagnosed at a younger age and sadly will die at a younger age as well. They have a trend towards higher grade and more hormone receptor negative disease. We found germline markers that are more prevalent and differences in somatic mutational signatures and HR deficiency profiles. And this is very important perhaps for therapeutic windows. And most importantly, I would say the ethnicity-adapted screening window is needed for greater equity in screening. We found that the current screening window between the age of 50 and 70 would miss a higher proportion of younger breast cancer cases in the ethnic minority groups. When we submitted the paper, one of the reviewers came back and said, you know the biomarkers for drug response from the whole genome sequencing on your sequenced cohort. Can you link it to what they've had in the hospital and tell us whether this aligns, whether you could have predicted the response or resistance? Now, this is easier said than done. If you've worked with treatment data from the HR system, you know that it's very difficult to harmonize and work with. But we had a cohort that was sequenced and with the full EHR very well, and we annotated the treatment data, and we found that taxane was prescribed to patients that have a predicted resistance based on their HR profile. And this could have prevented, perhaps, the progression in those groups of patients. And we also found that PARP inhibited would have been beneficial for up to 30% if the BRCA and PALB2 mutations, which are increased in the African cohort, were considered for those group of patients. Now, a quick example on pancreatic cancer. I will show you how we've aligned the visits that the patients has had in the hospital, collecting all this clinical information throughout their sequential visits during their clinical care. And we've done it on a patient and a cohort basis. So this is a small number of patients that we've looked at. We've aligned their data from the first interactions throughout their follow-up. So at the time where they've had the surgery, whether the tissue and the plasma were available, what treatment they've had, etc. And I will just focus on patient 45. And this is where you align the visits with the information from the clinical record and the samples that were available. And for the samples, for the plasma that was available from visit B to E in the study that we've looked at, we've looked at, as bioinformaticians would do, we looked at clonal evolution. So these P1, P2, P3, P4, and P5 are the visits B, C, D, and E. And you could see that you could align the clinical information at each time point with the clonal evolution and understand, overlay the clonal evolution with the clinical record of this patient. My last example is the field cancerization. We are interested in understanding the clinical utility of field cancerization and defining risk of breast cancer recurrence. And this is very important, especially for young women with breast cancer after having breast conserving surgery, because frequently the cancer will come back and recur at the primary site or a secondary site. So working with the pathologist of the Breast Cancer Now Biobank, Professor Louise Johns, we were able to take samples from the primary tumor, and within different distances in the normal adjacent, the morphologically normal appearing adjacent tissues, the proximal and the distal tissues, we've sequenced those, linked them to the EHR, and this is very important in terms of survival, therapeutics, and resection margins, because we were able to show that the morphologically normal appearing tissues have molecular changes that we've classified into 4 subtypes, with the metabolic being linked to poor prognosis and the immune being linked to good prognosis. And when we looked back, and this is an example of one of the patients that had the molecular subtype immune, this is a triple negative breast cancer that went into remission after having the triple negative diagnosis. Now, this is very important and will require a validation in a large cohort, but it would be fantastic if these molecular subtypes could be validated, because it could help better manage this group of patients. And I will end here, and I'd like to thank the biobank teams and the clinical PIs, Professor Hamad. Oops. Sorry? My time is up? Okay, so the clinical team, the biobank team, and everyone who's contributed, and this is the work of many people, not just myself, so thank you to all of them, and the donors, the patients without whom none of this work would be possible. Thank you very much.
Thank you very much. You come and join us here. And great to see the faces as well with the acknowledgements, so thank you very much for the human touch. Listen, we have time for a couple of questions. A very interesting topic, flashes into the future. Lots of challenges when it comes to treating data at scale, questions of confidentiality, collaboration, etc. Yes, we have a question here.
Yeah, question to Claude, a very interesting talk. The breast cancer data, you called it field cancerization. I think there are also data from Dr. Ogawa from Kyoto in Japan, who has published in Nature that normal-looking epithelial breast cells can have all kinds of cancer-associated mutations. The question is really, is that field cancerization, or is that just something that happens in people if they get a bit older?
Yeah, there's a microphone just in front.
Yeah, brilliant question. What I didn't say is that all our cancer cases were premenopausal, young women with breast cancer. The field cancerization, there are many theories, whether it's a reaction to the tumor or does it precede the tumor, and what is their role in recurrence. But our group and others have shown that sometimes, and there was a large study on the TCGA course, sometimes they have the ability to predict prognosis better than the tumor itself. So there is a lot of interesting, I would say, science there to dig in and try and understand more.
Thank you.
Watch this space. Work in progress. Yes, do we have another question on artificial intelligence looking towards the future? Because I suppose any questions online? Any questions? Another question on artificial intelligence? Because the other question maybe for you is also getting the right balance between artificial intelligence and the human intervention. How do we get that balance? How do we get the right mix? What do we have to keep in mind when it comes to treating cancer?
This is very important questions, I think. And anyway, artificial intelligence is a very useful tool for the medical fields, indeed. But I think that if, for example, the clinician just depend on the judgment of the artificial intelligence is also the very, very critical issue, I think. That too much artificial intelligence is not for healthy, in my opinion. So that's the reason we need to consider the balance between the artificial intelligence and the human clinicians. So, but anyway, recently the progress of the artificial intelligence technology is very, very quick, and maybe you know the recent generative AI produce a lot of the very, very important topics. Maybe superior to, in some aspects, superior to the maybe the human researcher or human the physician. So we need to consider the advantage of the artificial intelligence, but do not depend on the artificial intelligence too much. This is my opinion.
Okay. Any other questions? Yes, from the audience.
One quick question. I have several, but just one. I mean, you showed that most of your applications are narrow AI. So do you think that that is the first level that for the implementations that you both want, because you want to go with the EMR and the things, and the clinicians, that the narrow AI is going to be the most rapidly picking up?
Yeah, so okay. This is also a very important point. So I think important point now is the robustness of the artificial intelligence. Yeah. So for just research application, we can do a lot of things. But if we'd like to apply our data for the clinical settings, always limited the achievement is available. Because as you may know, the domain shift is one of the serious issues of artificial intelligence. If institute is different, and sometimes the accuracy of artificial decrease. So we need to consider the very, very sophisticated strategy for getting the acceptance from FDA or some of the regulatory institutes. So, yeah, but a very, very important point. Yeah.
Okay, maybe just finally, Professor Shulala, optimistic in the UK that we can do this at scale, that we can have participation 100% across the medical sector. You talked about various hospitals submitting data. The data lake becoming now the data ocean as well.
Yes, absolutely. But this is what the reason I've presented the genetic ancestry study is if the AI models are not trained on diverse data, we risk leaving a lot of people behind. You know, in GWAS studies, 80% of the findings are on people from a white background. And I think there is a lot to be discovered on ethnic minorities or non-European ancestry. And it's very important that the data is diverse as possible. So in the UK, we focused on African and South Asian cohorts. In US studies, you'll find East Asian or other ethnicity. And I think it's very important that we make sure that the AI is trained on diverse data, or we're going to repeat the same thing again.
Okay, thank you very much. Fascinating. Oh, we have another question. I think we're running just a quick question and a quick answer.
A question for both for the future. What about the clinician who do dermatology, who do imaging? Do you think they will disappear?
We'll still need their advice, won't we? Answer here. Any answer?
I think it's to help, not to replace. I don't want to go and see an AI dermatologist, or I mean personally. So I think it's to help. It's the same with pathology. Digitizing pathology is very important. It's happening, but it will not replace the pathologist. It will make their work easier. And one of the major hurdles in biobanking is to get engagement for pathologists who are very busy in their clinic. And you need them to look very thoroughly at the tissue specimens that are coming out to make sure that we are actually having good quality data. So it's to aid, I don't think it's to replace. But it's very important we train it properly. Yeah.
So a good partnership. Great. Thank you very much to both of you for these fascinating insights. Thank you very much.